Thank you.
Okay. Let's see. Well, this was a patient that I presented first on April 14th. And I believe Dr. Gilfus was here that day, and also Jean Colonel was here that day. So it was a guy that we thought, I was wondering if he needed to be put on the transplant list, but Dr. Colonel explained some helpful things about that. He had an AFP of 17.8, which was concerning. So what the recommendation was from Dr. Gilfus is that this guy thought he was diagnosed in 1980 or 81, but that was not correct, even though he told me that again a couple of days ago. But there was concern if he was compensated or decompensated cirrhosis. So I referred him to gastro, and he also scheduled an MRI. And when he went to gastro, they did an EGD with multiple cold forceps biopsies and applied 4 bands to the esophageal varices. And they diagnosed him as being grade 4 and having severe congestive gastritis. And then he had been having a lot of rectal bleeding, so the colonoscopy showed polyps and prominent internal hemorrhoids. The MRI was done, and you can see there it shows enlarged nodular surface liver without mass, intrinsic hepatic fibrosis compatible with cirrhosis. His spleen was enlarged, and he had ascites. So he was having a hard time breathing. He had done fine up until this point, and so I referred him back to GI, and then he had a paracentesis with 2.2 liters removed. And then he was started on Lasix and aldactone and viewed as decompensated and to treat with Exclusion for 24 weeks. And the gastroenterologist did refer him to UK Liver Center for possible future needs. So this is the last step that I have in presenting him today to see if there is anything else that I need to do before trying to get his medication approved. And right now he is doing fairly well. He's only had the 1 paracentesis. He has applied for disability, but actually he started a new job, and it is a desk job. He was a cook, but he was having difficulty standing on his legs all day. He was having swelling. So this is the follow-up, and I'm open for suggestions.
Thank you so much, Tammy. We always appreciate a follow-up case because we just learn so much from that, and we can kind of follow the progression. So we really appreciate that so much. I'm happy to keep the case up for anyone who has any questions.
I have questions.
Sure, absolutely.
Oh, you can hear me now. Yay.
Yes, we can. Woohoo.
Good. So my first question is, where is UK Liver Center? Because I never heard of it. I want to make sure I have this on my radar for future use.
Well, the note, the doctor's note said UK, and I assumed that was University of Kentucky, but I'm not sure.
I don't know. Okay, maybe.
Yeah.
Okay, cool. So my questions would be, well, first, I guess, is what's the rush to treat? Because he has a lot of complications that I'm worried about. And sometimes when you treat them with these DAAs, when they have decompensated cirrhosis, they can get worse pretty quickly. So that's a concern.
Thank you very much, Jane. Any other, Dr.
I'm going to jump right on to that, Gene. I'm so glad you're here, by the way, too, because this is outside of my comfort zone. If we do discuss what therapeutic, actually, let me even rewind. It's interesting. So the gastroenterologist referred the patient back to you to treat.
Well, we had a few phone calls, and the PA that worked in his office called and said the patient had told her that I was working him up. And so he told her he would rather come here because it's closer to his home. But so we talked back and forth, and at first decided, well, I wasn't sure about doing that. And then that I could try it, but I still knew I needed to present this guy, and I would be happy to refer him back.
Yeah, it's an interesting. So it's funny. This is one of the sort of unwritten rules of these telehealth programs for Hep C. And by the way, what a compliment from this gastroenterologist group that they're referring him back to you for treatment. That's awesome. But one of the sort of unwritten rules is we in general, unless a person's absolutely refusing to like go to a liver center, I don't know that we have a real good right to treat a decompensated cirrhotic, simply for the reason Gene said. The nice thing about these DAAs is, for the most part, as long as we're not giving them amiodarone at the same time, or they don't have hepatitis B, these medicines really don't have a high propensity for harm, with one exception, and that's, in these precariously balanced patients that have like 3 hepatocytes that are keeping their albumin where it needs to be. But he scares me. And the fact that he's already kind of plugged in to go to UK Liver Center, which I don't know where it is either, it's Louisville or anyway, it doesn't matter, but he's going to go somewhere. I would defer it to them. Remember, there's also that concept there. He might be able to get and I don't know if this is still done, but sometimes the pool of livers can be even broader if you're hepatitis C positive, because they'll give you hepatitis C liver. That's probably not an issue anymore. They'll probably use hep C livers for anybody nowadays because they're all treatable. But anyway, like Gene said, there's no super hurry. Big picture wise, this is at a glacial pace. This has caused trouble over the past couple decades, 3 decades, and another couple months isn't the end of the world to wait. If you did have to treat him, say he's like comes back to you and says, forget it, I'm not going anywhere else, I'm not doing it. And then if you did want to treat him, your options are limited to the non-protease inhibitor drugs. So remember, for decompensated cirrhotics, things like Mavorite and Zepatier are prohibited for child's PUC, and I think even B, everything except A. So your choices would be Harvoni or Epclusa, and you can give them for 12 weeks plus Riboviron, or you can give them for 24 weeks. And anybody who's used Riboviron, I can't remember us ever using Riboviron in the ECHO program. It's a challenge. You have to do frequent blood work. You can definitely induce anemia quite reliably, and actually could definitely be a predisposing factor for decompensation. So I'm not a Riboviron fan if you don't have to do it. But anyway, just for the sake of education, Epclusa or Harvoni would be the go-to. But I think you're doing great. You've done great by this guy. You've got him, you got him, his gastric varices banded. You've screened him for cancer. You're getting him plugged in with a liver center. I think you've done your due diligence. And like Gene said, I'm a little nervous treating this guy. But worst come to worst, if he tells you, no, I'm not going anywhere else, you've got those options in your back pocket. And if you did, you'd want to monitor him like a champ, like with visits routinely, and make sure that he's not getting encephalopathic or his liver enzymes aren't going up. Usually it's just liver enzymes going up, but anyway.
Yeah. Well, he said they told him that he didn't need a liver right now, and he might be fine for another 10 years, but he needed to be on the list.
Gene, you can probably speak to the timeframes involved. Usually if you're decompensated, it's more like a couple of years, but
Okay.
So what I would say to that is, you know, anything can kind of tip them over the edge. So he might be fine right now, needing to be on the list, but anything can really throw them over that edge and really cause an acute decompensation. So that's a little bit concerning because it could be any medication, not just Hep C meds, you know, any antibiotic, anything cardiac, all those things can do that. Even just because, you know, just because. So, I mean, this guy's pretty fragile. I'd probably be very hesitant to treat him too if he was in my clinic. Typically, you know, if they have varices, they need to have serial EGDs, especially when they're banding these things. So I'm assuming this guy has a follow-up in, you know, 4 to 6 weeks for a repeat EGD and all that. The swelling is a concern as well, because that can really get worse with these DAAs. Riboviron is really concerning. He's already anemic. His hemoglobin's in the 13s. You know, I've had some really bad experiences with Riboviron. We used to use Riba and interferon before the DAAs came on board. Nobody tolerates this well, and cirrhotics really don't tolerate them well. So, you know, they're neutropenic. You know, you're trying to chase that down. It's just a mess.
Yeah.
I would be very, very hesitant to treat this guy, but I think that everything you've done with him so far has been really bang on, you know, good job.
Thank you. So I will refer him back.
yeah. And Tammy, I did one time have a liver center send the patient back after they established. We're like, okay, you know, he's with us now. Go ahead and treat him. And, you know, it was almost under their umbrella, you know, but once he's established, if they say you can do it with caution, extreme caution. But yeah, not till they give you the go. I don't think Gene or I would want to give you that green light yet.
Okay. All right. Thank you, guys.
Anna, thank you all so much. Were there any other questions, Tammy, that you wanted to discuss with the group?
No, I don't think I have anything.
Okay,
Thank
no,
you.
that's perfect. And any other comments from the group, questions, feedback, recommendations? Alrighty, awesome. Well, thank you all so much. Thank you, Tammy. That was a wonderful follow-up case, and keep us posted if you want to do another follow-up on this follow-up. So we can keep up to date on that. Thank you so much. Gary, I have your 2 cases ready as well, so I'll go ahead and pull that up next. All right, are you able to see that okay? And are you okay starting with this case?
Yeah, that's good.
Excellent. All right, I'll turn it over to you then.
All right. This is a 37-year-old female. She's new to us. She told me she has a history of IV heroin use. She started in 2013. And she's been clean since 2021. However, before she started the IV heroin, she was doing cocaine and sharing straws with other people. She's not sure when she first started that, but she thinks it was approximately a year before the IV heroin. So possibly like 2012 exposure. She was just diagnosed last year, and now she would like to be treated. So exam-wise, it was normal. I did have an ultrasound order, and I do have the results now. The ultrasound showed moderate fatty infiltration and hepatomegaly, and the spleen was normal, and there was no liver masses or anything seen. She does have a history of depression, anxiety, and heartburn. She's currently taking Suboxone, bupropion, ferrous sulfate, quetiapine, and ropinirole. She is Hep B immune. She wasn't a Hep A, but those have been started since I submitted this. Overall, her blood work was not horrible. Platelets were 250. Her ALT was 439, and her AST is 180. The APRI score is 1.8. Child is 5A, the MELD score is 6. She is a genotype 1A, and the fibrosis score was F0 to F1. And when I did submit this, she was on omeprazole, but however, she has stopped that. She said her heartburn has been fine without it. So that interaction is gone. I just want to know, is there any other interactions I need to be careful with? Because I know the quetiapine can interact with Mavorite. So I'm assuming maybe Epclusa.
Thank you so much, Gary. All right, any clarifying questions from the group about this case? And everyone's welcome to chime in and unmute. All right, and any feedback and recommendations?
I don't know if Dr. Gilfus was going to chime in, but I'll chime in, I guess.
Let you go.
So,
For some reason, I was incompetent for a few seconds. I couldn't figure it out.
okay, well, I couldn't figure mine out either earlier, so that's okay. This guy or this lady sounds like a great option for treatment, I think. You know, she's clearly not cirrhotic, so good for her. If we can get her treated and she doesn't have any relapses, that'd be the best thing for her in the long run. So yeah, I think that she's a good candidate. And I just want to say, you guys treat some really sick people. I'm always amazed when I chime in here and like listen to this stuff, because these people are hard to manage. You know, some of these folks are really critical, and I'm always very impressed. But yeah, so this one I think looks like a really great case for treatment.
Oh,
And I'm really glad you did the ultrasound, because you had those sort of weird disparate APRI. Yeah, I think your APRI is just because her LFTs are so high. And but even I was looking at her white count and her ANC, this kind of got on the creepy low end of normal. And I like a tiebreaker because her APRI was high, the fibrosis score was okay, and yeah, you're good. I don't think, just recalculate her APRI to make yourself feel good after you treat her. And yeah, I like your Exclusion. I have to defer to Angie. Angie, didn't you just did your talk on the psych meds and the interaction with the?
I did. So for quetiapine and Mavorite, they say, so her dose is 400 milligrams a day. Their caution is for patients with higher dose of Seroquel, and they place that bar at 400 milligrams per day. But they say in patients with the more than moderate liver impairment, which it sounds like, refresh my memory, she does not have that, correct?
that's correct.
Okay, yeah, so I would say that it would be okay and just, you know, monitor her for any side effects or anything, but I would say it wouldn't be enough of a caution that if that's your only choice, you shouldn't go with it.
Okay. Thank you.
Thank you all so much. Gary, any other questions about this case?
Yeah, I just had a question, and that was the requip that the patient's on. Is that for restless leg or some other reason, out of curiosity?
She was saying it was restless leg. I don't have her full history, so she told me it was restless leg syndrome.
Gotcha. Okay. I had just, I don't know if anyone else is anybody who's having to renew their license this year, there's a cool didactic that you have to listen to. And there was a little bit of talking about how to be cautious with that drug in people with a history of addictions. Which I found fascinating. I'd never heard of that before, and then read about it a little bit. So anyway, if that's a soft diagnosis, maybe that drug doesn't have to be there, but that's it. Zero to do with her hep C, but more to do with her drug use history.
Yeah, it's interesting.
Yeah, I think the lecturer talked about compulsive behaviors and addictive behaviors. It can make them a bit more likely.
That's very interesting. Thank you for sharing that, Dr. Gilfus. Any other comments, questions? All right, Gary, and are you ready to go to your second case?
Sure.
Alrighty. All right, there you go.
This one I think is straightforward. This is a 37-year-old male. He has an IV drug use history. Heroin was his drug of choice. He started about 7 years ago, and he's been clean for the past 8 months. He found out he was hep C positive when he entered rehab. and he's currently still in drug rehab. He drinks socially on the weekends, and he uses medical marijuana for anxiety, and he smokes a pack a day. He has a history of hyperlipidemia, anxiety, and hemorrhoids. Exam was normal. He's only on Colace. He is immune to Hep B. Hep A is not, but he has since started his series. Labs. The ALT was 59. Platelets was 300. Sorry, my voice is going out. His iron was good. His vitamin D was good. He's genotype 1A, fibrosis F0, APRI is 0.4, child is 5A, and MELD is 6. I didn't do any imaging on him because it's been less than 10 years, and I think overall it's pretty good, except a slightly elevated LT. So I'm assuming Maverick or Epclusa would be appropriate. Do I need to do any imaging?
Thank you again, Gary. Yeah, no, open for questions, feedback, Dr. Gelfus.
I remember how to unmute this time. You know. Hey, Gary, I'm always so impressed, man. Your presentations demonstrate such advanced understanding of everything. I have nothing to really suggest to this one. I would not image. I don't think you need it. Just Maverick and done. 8 weeks of Maverick and done. And that's wonderful news. But yeah, you got the time frame in there for us and the establishment of risk factors and timelines and all that stuff. And yep, great job. Maverick, of course, that's 8 weeks, Epclusa 12, no HCC screening, and this should be a slam dunk. So good job, good presentation.
Thank you.
Thank you both very much. Any other feedback?
And thanks for putting the quantitative hepatitis B surface antigen on that. That's always, I love seeing that myself. So was his, did he have a core positive too, or was his from vaccination? Do you recollect? It doesn't matter. It's purely my curiosity.
I think it was vaccination.
Gotcha. Okay.
Give me a second, I can look it up. His Hep B core was negative, so it's vaccination.
Beautiful. Okay.
And this is Jennifer Boyd. I have a quick question about him. So his, and this might have been true in the previous case, I can't remember. His vitamin D was normal, but low normal. Would you still recommend some replacement just to raise his level?
Dr. Feinberg would.
That's why I was asking.
Yeah.
Thank
Yeah,
you.
I've not seen the literature that tells me what the optimal level is in this situation. So I think of less, he doesn't have advanced fibrosis or anything like that, and we're going to treat him. But for all the other reasons of well-being and bone health and other stuff, I'll defer to you all because you're smarter at primary care than I am. From his liver, I don't really care. Dr. Feinberg would, she'd want him 50 to 60. But I think you're going to treat him regardless and cure him.
Okay, that's why I asked. That was helpful. Thank you, because I've heard Feinberg say that.
Thank you for that question, Jen. Any other questions or comments or feedback about the case? And Gary, any other questions you had you wanted to address with the group?
No, I think that's all. Thank you, guys.
So no, thank you so much. We really appreciate it. Alrighty, so we'll move over to the didactic portion. Jean, I got you with the screen sharing, so I'll pull up your case for you. Just let me know when you would like me to go to the next slide.
Okay. So this is just a presentation on acute alcoholic hepatitis versus alcoholic cirrhosis. You know, everybody always makes the assumption that anybody that's in the hospital, they always have cirrhosis, depending on, you know, they came in for liver disease or whatever they came in for. As soon as they see alcohol, they assume it's the cirrhosis every single time, it seems like. So I thought this would be a good presentation. You can turn it. So on the scale of, fibrosis and how all of that develops, alcoholic hepatitis is in that inflammatory response stage. Unfortunately, the symptoms can look very much like alcoholic cirrhosis, but if you take away the offending agent, the symptoms will resolve over time as long as they can maintain abstinence. I just thought this was an easy way to look at things. Okay. So for acute alcoholic hepatitis, obviously, you can develop fibrosis from this over time, and you can get chronic liver disease, you can get chronic, obviously cirrhosis. The symptoms can look very much similar. So you can have somebody who has, what I tell patients, I'm like, in one hand, you're acute, and the other hand, you're chronic, but all the symptoms look mashed up and all a mess. So you can have jaundice, you can have bleeding, you can have swelling, you can have confusion for both. You don't get liver cancer when you have acute liver disease. You can get it with liver cirrhosis, okay? So, typically your acute alcoholics, they have high alcohol use. They've done this off and on for years. Typically they get sick and they stop drinking. So you have these episodic abstinent periods because they feel bad, so they quit drinking for a while and they resume it again. So you may not ever see them until it gets to the point where they can't get out of that sickness. And so that's when they present to the hospital or to your clinic and they're yellow. Sometimes, the symptoms that we see, severe jaundice, severe anorexia, typically their liver's enlarged. Now you'll still see it enlarged, some with cirrhosis, but over time cirrhosis, it shrinks up. Usually the lab presentations that you're going to see is that AST is going to be more than 2 times the size or the level of the ALT. You'll often see GGT elevations and bilirubin elevations. If you look at the ASLD guidelines, that's what's in red down there. ASLD, which is the American Society for Liver Disease, they particularly talk about that AST to ALT comparison because the ratio is what's important when you start thinking about how you do, differentiate these things out. With cirrhosis, you can also have acute onset hepatitis on top of chronic liver disease. So you can be, cirrhosis and drinking, and then you can have sort of this acute episode. So you have acute on chronic alcoholic liver disease at that point. Okay. These are the mortality rates, and these are kind of important because whenever we start thinking about, this is for cirrhosis, but when we start thinking about acute hepatitis from alcohol, that's on my next couple of screens, you'll see the mortality rates are pretty similar, which is kind of scary. So for cirrhosis, you can have cirrhosis for a long time. If you get to complications, the complications are what causes the mortality, generally speaking. So, you get confused, you have a higher mortality rate than even if you have cancer, which is really kind of disturbing. But I think these are important to think about. The patients complain the most about the fluid, but that has the least or the lowest mortality rate overall. They don't seem to complain as much about the bleeding hemorrhages, the variceal hemorrhages, but those are the patients that are going to, have a higher death rate on your hands. Those are the ones you got to look out for. So these numbers are kind of disturbing when you think about, these are very comparable for somebody who has end-stage cirrhosis to somebody who has acute alcoholic hepatitis without, scar tissue in the liver. Okay. So acute alcoholic versus Linux, same size, same management, same symptoms, but how do you differentiate? That's always the question. Okay. The simple way to say it, or what I teach patients, is the way you determine if it's acute versus chronic is you take away the offending agent. If everything resolves, it's acute. Okay. Which is just a really simplified way of saying it, because typically these cirrhotics that are drinking, if they take away the alcohol and things get better, they still have cirrhosis, but their symptom management resolves. So there's a lot more to it than just taking away the agent, but that's how I try to get patients sort of to wrap their brain around this. But the biggest difference is the mortality rate. So the mortality rate for somebody with acute alcoholic hepatitis is up to 50%. It depends on which group of trials or reports you want to look at, but up to 50% death rate for these people that don't have cirrhosis, that have an acute episode. Those rates are almost as high as somebody that has chronic cirrhosis, chronic complications, and these people don't have scar tissue in the liver. So it's really pretty disturbing. The biggest thing I think that people don't understand is, when I see them outpatient, I tell them, there's never a safe amount of alcohol. And that's what I try to make them all understand, because they'll be like, oh, my dad drinks, a case a day. Okay. But, and I only drink 2 beers a day. Well, it doesn't matter. Your liver can't tolerate it. And they don't seem to understand this. So really, I try to stress that there's never a safe amount of alcohol that's okay to drink, especially if you have additional liver damage at all. So if you have fatty liver, you have hepatitis B, whatever, really you shouldn't drink at all, even without cirrhosis. Patients really give a pushback on that. So then I hedge my bets and tell them to limit their alcohol, because they really don't want to hear no alcohol. Okay. In the hospital, when you come into I don't do hospital care, I only do outpatient. But when you come into the hospital and you have acute alcoholic hepatitis, we do this discriminant function. It's based on all your lab tests. You just plug it into your MedCalc and it'll spit it out for you. Anytime you have a discriminant function over 32, their 3-month risk for death is incredibly high. I forget the rate, but it's incredibly high. So anyway, we always track it by discriminant function, and that's the determining issue as to whether or not they get put on steroids. There's a lot of mixed information about steroids too. The ASLD guidelines say that steroids decrease 28-day mortality. However, we see a lot of people have adverse events and they actually die from steroid complications. If they have infections or they have other underlying problems, you have this inflammatory response from alcoholic hepatitis. And so everything is sort of inflamed in the systemic level. And then you stick steroids on top of them, everything else inflames as well. So any underlying issue can make this worse and they end up dying. We really stress doing the Lille score at that 7-day window, because that'll tell us how well you're responding to steroids. There's old data that says instead of using steroids, you can do pentoxifylline. Pentoxifylline doesn't do enough for these acute patients to even warrant doing it. Okay. So there's been some push from ASLD to consider, medications for cravings for alcohol to help these people get off of the alcohol. And there's a lot of medications out there. The one that really drives me bonkers, I see a lot, is Vivitrol. Vivitrol is not recommended. It's not even reviewed by ASLD. It actually causes hepatotoxicity. And that's a very common drug. If these patients go to a alcoholic rehab center, Vivitrol is something they use regularly. This can actually cause liver failure and death. So I don't like that one at all. The safest ones, honestly, is going to be your Baclofen and your Camprosate or your Kempel. Baclofen is a newer recommendation from the ASLD guidelines. Baclofen, obviously, it's a muscle relaxer. People get very up in arms about it whenever I write a script for it, because they're like, oh, it's going to be sedating. They can't take that. They have liver disease or it's addictive or whatever. But the ASLD guidelines say that this actually helps to control alcoholic cravings. I've had patients with decompensated cirrhosis on low doses of this. They do really well. So usually what I put them on is about 5 milligrams 3 times a day, just to kind of get them away from thinking about alcohol, because that's the bigger issue. If I can get the alcohol out of the system, the liver can recover enough, then it can tolerate the Baclofen, it can tolerate this other stuff. Their cardiac meds or their whatever else they need, and the fluid will be better controlled if they can get away from the alcohol. Campril, I don't write for, but I've used or recommended Campril for a long time. This is renally excreted, so it's a better choice than that Vivitrol. The liver seems to do pretty well with Campril. Decompensated cirrhotics can handle Campril. So I like that one. And it was nice to see ASLD come on board and say that this is a good option, because that took a long time coming for that to come out from them. Gabapentin is often used off-label for this too. This is nice too because it's renally excreted. Just be really careful with gabapentin. If these people have any encephalopathy at all, you want to start really low and go slow. So I start, usually if I'm going to write it, I write 100 milligrams once a day, increasing to 3 times a day. And then from there, I'll increase to 200 at a time or 300 at a time. But really, they don't tolerate very high doses of this. They can get sedated quickly. Topiramate, I don't ever see topiramate or naltrexone prescribed, so I can't tell you how well they do or don't work. You know, what I always worry about is that it's going to be hepatotoxic. There are some drugs that are just known to be that way. Naltrexone is one of those, just like amiodarone is one of those. So there's just few of them that have come out, and really Campril and Baclofen are the best ones. Okay. You know, a lot of people ask about biopsy, and a lot of locations are really quick to biopsy people. I'm not. A liver biopsy is not usually indicated. Sometimes it's really not helpful at all. It can really give misleading information. You can get readings if it's alcohol that you're trying to target. Okay, if you're trying to look at acute alcoholic hepatitis, you know, unfortunately, alcohol it breaks down as sugar. Sugar in the liver looks like fatty liver. So you do this biopsy and you think you're going to see, oh my gosh, they have alcoholic liver disease, but all it shows is they have fatty liver disease. You know, everybody gets on this track of Mallory-Denk bodies and, you know, the ballooning and all of this stuff, all this terminology. The problem is it all looks the same. Fatty liver from metabolic syndrome and fatty liver from alcohol-induced liver disease looks the same on a biopsy. So it's really not helpful. So that's usually like if you're abstaining for months and months and months on end, LFTs are still elevated, you don't have diabetes or anything like that, then we maybe would recommend the biopsy. But as a general rule, they're not always helpful. Okay. For transplant abstinence criteria, used to always be 6 months. There was this hard and fast, you had to be abstaining for 6 months before we could even think about referring for transplant if you're out of the hospital. In the hospital, it's a different story. So if you're in the hospital for acute alcoholic hepatitis and your MELD score is 30 and you're in organ failure, you know, there are a few locations around, as long as you have certain insurance, there are a few locations around that'll take you for a transplant, like Baltimore. Pittsburgh, not so much. Okay, you have to be 6 months out still for Pittsburgh. I don't know what Cleveland Clinic is doing at this point as far as alcohol. There's been a push from the European Society for Liver Disease to change that, but it hasn't really filtered through the US at this point. Outpatient, like I said, hard and fast rule for 6 months for a long time. Just in the last year or two, they started to consider people that are maybe 4 months abstinent and their liver is really struggling, their MELD is not improving. You know, they're not going to make it to the 6 month mark for sobriety. They're starting to consider those people for consideration for transplant. You know, there's been maybe a come to Jesus meeting. Oops, sorry. There's been a come to Jesus meeting, I think, about some of the minds that think about alcohol. You know, a slip up of alcoholic use versus a relapse. There's a difference in terminology, but there's a difference of way of thinking about it. You know, from the patient's perspective, if they slip up and they're like, oh my God, what have I done to myself? I got to quit drinking. I'm not healthy this way. That's a slip. Okay. So it's really important to think about how you the terminology that you use, how you term it on your write-up if you're going to try to refer them for alcoholic liver disease for transplant. Okay. Transplant exclusion criteria. I can tell you what I see from Pittsburgh all the time, from both UPMC and AGH. Both of them, you have to be hard and fast abstinent for 6 months, okay? That just hasn't made it across the United States as yet. They will also decline you if you went through a rehab program and you relapse after that. That's a big no for them. If you've not been to a rehab center and you are now abstinent and it's been 3 years and you need a transplant, they're still going to make you go to a rehab center. So, you know, they really want to see that knowledge base for the patient to know that alcohol is a problem, why it's a problem, how to abstain from it, how to get those supports to keep them clean. There are many other exclusion criteria. I listed them all here, but you know, the MELD score is probably the easiest one to think about for everybody else. And I'll just try to keep track of all these other things. But MELD score somewhere between 16 and 18. And if it's not up there, they're not getting a transplant. They won't even talk to them. There's no reason to refer somebody with a MELD of 11, even if they're confused, they have fluid overload, they're, you know, vomiting blood. None of this is going to matter if their MELD's too low. Okay, that's it. Short and sweet.
Thank you so much, Jean. That is the best way. We really appreciate it. Thank you so much. Did anyone?
Jean, that was awesome. Just appreciate it.
Oh, thanks. Thank you.
Absolutely. Thank you, Dr. Gilfus, for that compliment. Any other questions or comments for Jean? And I'll be sure to attach your PowerPoint presentation in the recap so everyone will have a copy of that as well. Alrighty. It's a quiet group today, which is not a problem at all. But if there are ever any questions after the fact, you can always email us and we'll send it over to Jean to have addressed. The only announcement that I have is that the next session will be on July 14th. And Dr. Gilfus will be presenting on HCV and HIV. So keep an eye out for that reminder. We got a chat in from Tammy's thanking you very much, Jean. So thank you for chatting that in as well, Tammy. All righty, we'll see you all next time. Thank you all so much. Take care.